Ellenor Mittendorfer-Rutz, she came to us at the Division of Insurance Medicine as a postdoc in my research group more than 10 years ago. And you have had a marvelous development integrating your expertise in psychiatric epidemiology with insurance medicine. That was needed to be done, and you've done that. You also have a wide previous experience of different type of jobs, for instance, with the United Nations in different countries, in suicide prevention, and now you also have taken on aspects related to a great issue in today's society, and that is migration within the realm of insurance medicine. That is great. You proceeded from postdoc to senior researcher to research group leader and is now the head of the Division of Insurance Medicine. I'm not that. I'm very glad that you have taken over that. We are now looking forward to your lecture, which is also your inauguration lecture. So the floor is yours.
Thank you, Christina. During and after Second World War, to be exact, from 1939 to 1950, 30 million people migrated. That's 3 times the population in Sweden. An enormous amount of people. Today, it's twice as many people migrating. 68.5 million people are forcibly displaced worldwide. 40 million people are internally displaced, 25 million people are refugees, 3.1 million people are asylum seekers. And this is, of course, an enormous political issue. What I try now in the next 40 minutes to show you that this is not only a political issue, it is also an issue for insurance medicine, it's an issue for healthcare settings, and definitely an issue for research, because we need the evidence on strategies and also understanding differences in treatment in order to have culturally sensitive treatment strategies. This is also the reason why I've chosen this topic as my inaugural lecture, because as Christina mentioned, I'm also working with a number of other issues within insurance medicine. We're talking a lot about how many refugees came to Sweden. I think most of you are from Sweden. This is certainly true, but 85% of the world's refugees are hosted in neighboring countries. Actually, to be precise, in African and Asian countries. So they are taking the burden, if we want to say so, of hosting these individuals and also finding solutions. It's not us in Europe. Within migration research, we have to focus on pre-migration factors. This is a picture of a war zone in Syria. We have all seen them. And these pre-migration factors are, of course, for refugees, very often traumatic experiences. This is also a picture we have seen very many times, unfortunately. People rescued from the Mediterranean Sea. So what we have to do in migration research is also to look at migration factors, meaning all the obstacles people have to overcome to come to European countries or to other westernized countries. I've been very often thinking when I'm listening to the news that people have been dying in the Mediterranean Sea, what I would take with me and when I would decide to flee, if I had to. Here is an example of a person called Nur. He is 20 years old, he's an artist, he comes from Syria. He left the country when he heard bombings in the surroundings. And on the right picture, you see what he took with him. It's some personal documents, some presents from friends, a rosary, and also some other issues which he's very close to. A cell phone and a shirt, not more. Basically because people taking him on the journey to an European country told him that he cannot have more than this. And talking about these issues, I think we always have to also remember that people having an experience of being a refugee are very strong people. They have to overcome all these obstacles. These people all have something in common. We all know them, right? And they are all refugees. They have all these made this experience. In migration research, we call it the healthy migrant hypothesis or the healthy migrant effect. Migrants are most likely to be more healthy and also strong and have resilience factors than other people. We also have to consider post-migration factors. This slide here shows you the result of the World Value Survey. It's a survey which is regularly taking place in all different countries in the world. What you see here is the countries depicted on an X and an Y axis, showing the degree of secularization in the country and the degree of individualization in the country. You can see that Sweden is on the top right corner. This means that Sweden is, according to this survey, the most secularized and the most individualized country in the whole world. This means also that people coming from countries which are, as you see on this map in the left down corner, have an enormous difference in culture, right? It's like as we would have been kind of catapulting in a society kind of 200 years from now. We have to keep that in mind when we're doing research and also when we are treating people with mental disorders. Why did I choose mental health for the topic of this talk? It's of a very big public health issue, but also because migrants are often shown, at least some groups of migrants are often shown to have higher degrees of mental disorders. Here I'm showing some slides of a recent study carried out in my research group about prevalence of diagnosis specific healthcare and specialized healthcare in Sweden. What you can see is that you see in the second column the refugees and the third column people born in Sweden. For most of the disorders, actually for all of them besides bipolar disorder, refugees have a higher prevalence. Most of them twice as high, for example, if you look at depressive disorders. If you look at post-traumatic stress disorders, maybe this is not surprising, but they have, refugees have a 10 times higher prevalence rate. This is also, even if it's specialized healthcare data, it's in line with other research findings, doing surveys with other methods of measuring mental health and mental ill health. Some words about healthcare and treatment in migrants and particularly refugees. I'm sometimes saying migrants in order to have a word kind of encompassing all the groups. But of course, this is a huge heterogeneity in this group, right? There are very many different cultures and many different people and many different stories. Some differences, however, we know. We know that there is a lower access to health care, at least in some countries. We know also that the help-seeking behavior, particularly for specialized health care, is lower in refugees, most likely due to the stigma attached with mental disorders. We have stigma here in Sweden as well and in other European countries, but in other cultures it's much more dominant. Language barriers, of course. We can also not assume that there is a competence in transcultural psychiatry and psychology in all the healthcare stuff in westernized countries. So there might be differences in treatment. And one issue which I also want to spend a little bit more time is suicidal behavior. And why do I want to do that? Well, because mental disorders are the main risk factors for suicidal behavior. And we don't really know how it differs in migrants, particularly in specific migrant groups. Actually, when I started this type of research, I looked in PubMed and I didn't find a single study which was considerably representative on suicide attempt in refugees. I know that not all of you are suicidologists, so I want to kind of share a little bit of background knowledge on suicidology and also on the suicidal process with you. This is one model. There are different models. Here it is depicted as starting with a state of a crisis. Can be a mental disorder. It can also be a specific life situation, difficult to tackle. This might lead to depressive thinking and hopelessness, which is a very strong driver in a suicidal process. It can also lead to psychic pain, a situation which is nearly unbearable. And what happens very often in the suicidal process is that it leads to tunnel thinking. You have no possibilities any longer to have coping strategies. The only way out is to take your own life. And of course, needless to say, this is associated with a lot of suffering. I'm showing you now some results from different register studies, and just to give you a little bit idea about the study design. It's based on different national registers. We have been using here a cohort, meaning a group of people from 2004, and all were between 16 and 64 years. It were in total 4.9 billion in the host population. Host population we call the population where refugees have been resettling. And approximately 197,000 refugees. The exposure was measured in 2004 as refugee status. We followed from 2005 to 2013. We looked at suicide attempt or self-harm, which we often call it, to have a larger group of patients included, and suicide, and a number of confounders. As I said, there were no studies on refugees, so we actually hypothesized that given the fact that they have higher rates of post-traumatic stress disorders, they have been going through a lot of difficult life situations, all of which are associated with suicide attempt. So there was, of course, no doubt to understand that they must have a higher suicide risk, right? Here is the reference group, people born in Sweden, and we wanted to know what the self-harm risk in refugees are. Contrary to our hypothesis is that they had a lower risk. This has not been published before. And actually, as I said, it's a heterogeneous group. We wanted to look at different countries. This was the case for almost all countries, with the exception of Iran. Not going into too much detail in the interest of time. With regard to suicide, because we looked at that as well, all countries from different refugee groups had a lower suicide risk. Of course, the next interest, as we know, mental disorders are the main risk factor for suicidal behavior, was, of course, is this the same when you look at specific mental disorders? Would the suicide risk even be lower in refugees then? Here you see those with no mental disorder, and those born in Sweden are again the reference group. It was more or less the same. Here the difference was even larger. Refugees had a much lower suicide risk. This is a paper with Emma Björkenstam, also a colleague from my research group. And we looked at the specific different mental disorders, all of them with two exceptions. Refugees had a lower suicide risk. And this is self-harm, but the same thing was found for suicide. With two exceptions, with schizophrenia, personality disorders, very severe disorders, particularly if they lead to specialized healthcare. So there might be other driving forces behind them. In 2017, I think all of you can remember, it was more or less every week any kind of information about a new suicide occurring and committed from an unaccompanied minors looking for asylum in Sweden. Actually, in February approximately, humanitarian associations were starting to discuss this as a very strong problem. Mainly those people who came 2015 as unaccompanied minors to Sweden was more than 35,000, many more than previously came. The problem was that there was absolutely no information apart from this anecdotal evidence in newspapers how large the problem is. I'm an epidemiologist, and of course it was a situation which was absolutely clear for me that we have to know this. Interestingly enough, everybody in the research community agreed that we cannot know because they don't have a residence permit and therefore also not a registration number. It turned out that you can, so I want to give a positive impression of this study. It was one of the most rewarding I ever did. And I also want to give a positive impression in order to do these studies because it's important to do them and not to be discarded with regard to the difficulties you may encounter. We contacted 23 agencies, and most of them had no information or could not give us this information. The ones who could were the Swedish Migration Agency, the National Board of Health and Welfare, the National Board of Forensic Medicine, and 2 voluntary organizations. Without one of these voluntary organizations, we would have never known, because they have been collecting information on suicide cases among unaccompanied minors themselves. Of course, they couldn't know if it was suicide because they were not trained to do so, but they gave us the information. And with this information, we went to the National Board of Forensic Medicine and validated the data. So let's look at the findings. Suicide numbers, the population, and the suicide rate per 100,000 in individuals, both Swedish born and also those unaccompanied minors between 10 and 21 years of age. First, the Swedish population, maybe some of you know, 6.1 per 100,000, which is a medium to, mild to mediate suicide rate. When we looked at the unaccompanied minors, it was 8 times higher, 51.2. Actually, there's no country in the world which has so high suicide rates in this age group. Very alarming. Actually, normally when you see this as a clinician or as a public health specialist, you have to do something immediately, right? That's also what we said to the National Board of Health and Welfare, who funded this study. What else did we find? We find that suicide was the most common, nearly exclusively the only cause of death in this group. We also found out that the most common used methods was hanging. Hanging is a very lethal suicide method. So of course, this suicidal behavior was very, very intensive and very decisive. We found also of those who committed suicide in 2017 were exclusively boys or young men, and they were mainly from Afghanistan. And all had a history of traumatic experiences. It was a very sad reading. It was interviews from the Swedish Migration Agency. They didn't have one traumatic experience. It was one after the next, after the next. And those who committed suicide in 2017, they applied for asylum in 2015, so they waited for 2 years, all of them, most of them longer. It's a long time to wait if you have to go back to a country where you fear that you will die. So what we recommended in the report, I already said that, immediate suicide prevention methods should be taken in place, but also continuous monitoring, because we don't know if the suicide rate in 2017 was exceptionally high due to some reasons. We also don't know, because this is a field which is hardly studied, or if it has been going down. So in order to do any intervention, we have to know. Actually, this is also what the National Board of Health and Welfare and the National Board of Forensic Medicine agreed upon, that there will be continuous monitoring, which is very good and a result of this report. So what can we conclude from these findings with regard to the most serious outcome of mental disorders, the suicidal behavior between migrants and refugees? Well, obviously, there must be some common denominator, and most likely culture or religion, which is affecting and also affecting people to experience the stigma associated with mental ill health and suicidal behavior. Culture might also have an influence on individuals' attitudes towards suicidal behavior. So how do we think about this? Is it an option at all to commit suicide and also act on suicidal ideas? Because many people have that, but not all of them, of course, are acting upon them. Most people, most refugees came from Muslim majority countries with lower suicide rates, so this might have an influence, that this is also a culture which is quite restrictive or very restrictive with regard to suicidal behavior. But there might be protective factors. There might be factors we can really learn about and know more about suicidal behavior at all, and know more about refugees. So there might be more social connectedness. There might also be a stronger resilience. And of course, there might be suicide risk groups. I've been talking about the unaccompanied minors. So the lower suicide risk we found in those with a residence permit might not obviously be the same as in the unaccompanied minors. Now I've been talking a lot about mental health and mental ill health and suicidal behavior. I also want to spend the next 20 minutes on talking about insurance medicine. Also a field, refugees and insurance medicine, a field which is hardly existing, I would say. Some of you might not know what insurance medicine is, so I decided to take a very simple and very short description of it from the Cochrane Insurance Medicine Network. Insurance medicine covers medical assessments and interventions for all types of insurance schemes that involve health aspects, sickness allowance or disability pension for health-related incapacity to work. There are others, but those I want to focus on because those I have been mainly researching upon. Mental disorders have an early age of onset. We know that, most of them have. And we also know that it must have an effect on occupational functioning. We heard a lot about this in the previous lecture. What this slide shows us is data from the Social Insurance Agency from 2018 from Sweden, 19 to 29-year-olds who got granted disability pension. In the darkest color on the bottom of the slide, you see both for men and women that it's nearly exclusively mental disorders. People are getting disability pension in these ages, right? It's hardly any other disorders due to this very early age of onset. And as has been pointed out, this of course has a consequence also for the rest of their lives because people will have some of these benefits their whole life. That's also the reason why I decided to show some of the studies now in the next minutes on young people. When we're talking about sickness, absence, and disability pension, of course, this is within a wider framework of labor market marginalization. And young people having entrance into the labor market is of enormous importance. Of course, it is always important for all of us, but particularly for young people because it means so much for their identity building. What we've seen in a number of studies with labor market marginalization is that people mainly consider unemployment. I will show you in the next slides that this might lead to false conclusions. What we did, and we conceptualized labor market marginalization in this age group within a social insurance perspective. So we looked at sickness absence, disability pension, and unemployment. Because we've seen in the first studies that if you only consider unemployment, you disregard and also underestimate severely the social consequences of mental disorders, not only in young people, but in general. This slide is a little bit busy, so I will guide you through it. What you see is that in a group of people between 20 and 35 years, you see the risk of unemployment, long-term sickness, absence, and disability pension. And you see here those without a mental disorder. And the three indications you see in each slide is first for people born in Sweden, people born in Western countries, and those in non-Western countries. So those migrants born in Western or non-Western countries have a considerably increased risk of unemployment, a slightly increased of sickness absence, and a lower risk of disability pension. What happens if you have a mental disorder? Well, it matters for those people born in Sweden. They have a slightly higher risk of unemployment, but it doesn't matter for migrants, not for Western and not for non-Western migrants. It's actually the same risk estimate, most likely because the risk of being a migrant, if we may say so, is already very high, right? With sickness absence, migrants have a slightly lower risk when they have a mental disorder, and with disability pension, considerably lower. These analyses are adjusted for a number of covariates, so these are taken into consideration. This means that we have been controlling for the level of unemployment, for example. So the argument that people with a migration background are not in the labor market because they have a lower education is not completely correct. Because if we control for that, there's still an increased risk. So it must be something else also. And we have been controlling for being in the labor market in the baseline. And this means also that we have been controlling for something which is very central here, namely the eligibility criteria for getting sickness absence and disability pension to some extent, but definitely sickness absence, you have to be in gainful employment. Migrants are less often in gainful employment. That's why they can also are less likely to get sickness absence or disability pension. If we don't control for that, they would have a slightly higher risk. Of course, now I've been talking about disability pension and mental disorders. Of course, not all mental disorders are associated with the same risk of disability pension, right? This might be expected. What you see here is again in a young group. For specific mental disorders, you see first, for example, affective disorders, the risk, and you see on the x-axis that it is relatively high, approximately around 7, and also the next group, behavioral disorders, are associated with somewhat less risk. Everything is compared to people born in Sweden. Here we are not considering migrants, and or actually it is the whole population, it's also including migrants, and the reference group is those without a mental disorder. You see also that anxiety disorders and substance abuse disorders are associated with a considerable risk, but not as high as, for example, schizophrenia and non-affective disorder and personality disorder. Actually, among people with schizophrenia, relatively few are in gainful employment, but there are some who are, and of course we have to support them in this role. What you saw in the previous slide is something which we traditionally do and which is a classical epidemiological design. We have an exposure in time point E or time point A or whatever you would call it, and an outcome at a time point B. And then you have a risk estimate. But this is more or less kind of having a risk estimate for everybody with this diagnosis or everybody being a refugee. While in fact we know that these groups are very heterogeneous and there is a huge individual variation in the prognosis. So what we did to encompass this heterogeneity is to develop cutting-edge methodology to show differences in patterns. They're called group-based trajectory models. Again, somewhat busy, but I will guide you through. What you see here is T-3 is 3 years before you get a diagnosis of a common mental disorder, depressive or anxiety disorder. And T0 is when you get it. This again is young people. And the different graphs you see here are different trajectory groups with varying number of months of work disability and unemployment. We purposefully have been including this as a common measure to show the whole range of marginalization in this group. So you see that some groups are relatively high, we call them increasing high, and some groups are lower increasing and some groups are relatively low and are constant low. You also see the proportions of the people with the common mental disorders in this group. And this is again a register study which gives us the exceptional possibility to follow these individuals for a very long time period. We could follow them for 6 years. What you see here is then when you look at the 6-year, T6, that the first two groups, which approximately are 50%, have no labor market marginalization, at least not what we can measure. The other ones have 3 months or 6 months mean levels of labor market marginalization with benefits per year. I would not say that this is a very good prognosis, right? If 50% are after 6 years still dependent on some kind of social benefit. So it's quite a severe prognosis in this very young group. And of course, there is a lot of research necessary to understand better the pathways. What we can do with these models is to combine it with another analysis to show which characteristics can we attribute to these specific groups. And what we saw in these analyses and also in the analysis before and the conclusions we can draw is that, of course, the social insurance policies matter and the labor market policies matter. Because, of course, it matters which eligibility criteria we have and which gives people entrance to different sources of support. Education matters, but it's not the only thing, and I think we should be careful with this because this is what the media tells us. Morbidity obviously matters, But as we saw in the case of unemployment, actually there it doesn't matter. Area of living, it matters where you live. If you have faced more labor market marginalization with a mental disorder, it's much better if you live in a small city, in a big city, than if you live in the countryside. Then, of course, there are factors which we have not been measured and which should be measured and looked upon in future studies. And these are factors which are related to discrimination and also language barriers. And of course, political and labor market situation in the host country when people come. Some more findings. The patterns regarding sickness, absence, and disability pension are similar for Swedish-born and migrants from non-Western countries with a common mental disorder if you disregard the fact if they are attached to the labor market at baseline. But not non-Western migrants, they have a higher risk of unemployment. There are somewhat higher risk estimates in refugees than non-refugee immigrants from the same countries. We don't know why. We can have hypotheses, but there seems to be some kind of determinants who are driving more marginalization in these groups. And highest risk of unemployment is in refugees from Syria, Afghanistan, and Somalia, only some countries. This is an attempt to kind of show a little bit more the heterogeneity in this group of refugees, because of course they're not all the same. And the highest risk of work disability in refugees from former Yugoslavia, Iran, and Iraq. Two findings which also show us that something happens with time. Refugees with a longer duration of stay in Sweden, more than 10 years, have a lower risk of unemployment than those with shorter duration because they are assimilating to the society. They know the system better. They are more associated and more socially integrated into society, but they don't have a higher risk for disability pension, which also is related to the social insurance schemes. What I hope that I could show you in this lecture is that it's important to consider transcultural perspective in insurance medicine. Why would this be important? First, it is important in diagnostics. There might be differences, and we know from, for example, transcultural psychiatry, which has a longer tradition, that there are differences in the clinical manifestation of symptoms. We have to consider in the area of insurance medicine, when we are doing workability assessments, that the relation between symptom level and functional impairment might differ in migrants. Symptom level might be much higher, while people are better functioning. And of course, we really need cultural sensitive treatment and strategies and options. And these strategies should be, of course, person-centered. From the experience we have from person-based medicine, simply listening to the patient's story. In the end, I want to tell you a little bit about a new project, which I got funding from the Swedish Research Council, which we call REMAIN. It's called Refugee Minors and Integration. There we want to do some of these evidence-based generation with regard to treatment models. What we will do is to do comparative effectiveness of specific antidepressant medication in refugee minors and young adults with depressive disorder. We want to compare these findings in a group of people, young people who are born in Sweden. What we also want to do is to first time actually in Europe test a method which has been developed by the World Health Organization, which is called Problem Management Plus. It's a cost-effective, low-intensity intervention by lay therapists. Why would you want to engage lay therapists in a country with a highly specialized healthcare system? Well, mental health services are greatly underutilized by refugees. We know that from a number of studies. Interventions targeted to a broader range of symptoms are very useful because the majority of refugees present with general psychological distress. And also there is a scarcity of highly trained specialists because we have a lot of people with these problems. This is a paper which is published 2 months ago. Two of the authors are in this research group, which I just talked about in REMAIN. They tested this PM Plus in an area in Pakistan. They found very good results. What we want to do now is to first test it in Amsterdam, if this works, and then if it works, we want to test it also in Stockholm. Of course, the aim is that we will have a working and very effective method of helping people, young people with mental health problems as young refugees in the future, in other areas also, in Sweden and other European countries. This is closing the lecture. I think we need a transcultural insurance medicine. And the reason why we need is that we have to open a transcultural paradigm in this field. And why would we do that? It's important to meet the new challenges because we have changing societies. We have multicultural societies nowadays. We cannot ignore this. It will not change. It will increase because people are more and more migrating. And it's also important to answer to this increasing social cultural diversity. Thank you.
Björström asked if you in any way also are studying aspects of how the Social Insurance Agency now have a stricter application of the rules and rejecting some of the applications.
Specifically, we have not looked into this. What we did is to compare a cohort who had long-term sickness absence or got disability pension before the 2008 changes of the rules, right? There were very strict changes of the social insurance regulations in 2008, and after. The study design which we used is not really kind of easy to apply to conclusions if people would have a worse outcome or not, because obviously, if it is very restrictive, it's those people with higher morbidity who would get it, right? So their outcome would also be worse, because we looked at health outcomes. It's not easy with this study design to disentangle what the consequences of the social insurance regulations were and what the consequences of the high morbidity levels were. But this study design is, of course, kind of able to be broader and to open up, and definitely a very, very important question.
Simon.
Thank you. It's not a question, it's a comment. And I think, so first, thank you. It was a wonderful lecture. Very inspiring. And one of the reasons why I think it's inspiring as well is that a colleague of mine is mandated now to set up a national network for immigration health in Norway. So as a tool to try to emphasize and build up research expertise and activities around this in Norway. And so I think we're lagging behind you. So we can learn from you, which is great. And so your last slide was, I mean, you're at the next step already, because you said that you would like to start a new paradigm. So transcultural insurance medicine, was it?
Yes.
Yes, very nice and catchy. And I was just wondering if and I think, you know, obviously that would be something that would be very prone for collaboration. I mean, it's transcultural, so you would need to collaborate internationally. Yes. And so, do you have any ideas? What are the? Because I'd like to take that back and sort of try to build that logic into the rhetoric back home, and say, well, this is also an asset. We need to sort of look at this aspect of the problem as well. So do you have any ideas around what would be the first steps in sort of getting such a perspective and paradigm up and running? Have you sort of clear ideas on sort of which types of questions should we approach first? Which data should we really... so how far are you in building a strategy for sort of getting to that new paradigm, which is hugely interesting and important, I think?
Well, I think that what I've done, me and my group did up until now, is to show that there are disparities. There are also differences, right? We cannot assume that the patterns and prognosis are similar. We cannot assume that diagnostics is similar, because we know that from other fields, right? Even if transcultural insurance medicine, the birth is today, maybe. There is no such field yet, but I'm sure we need it in the future. then I think the first is to show that there are differences. So what we want to do is also to show with the treatment studies is that we cannot anticipate that, for example, antidepressants would work exactly the same in people with other ethnic backgrounds as they do in people born in Sweden. So I think that once the first evidence is out, it will be easier to convince people. Both the evidence, which I think we have collected to some extent, that there are differences in prognosis, but also then that there are differences in treatment. And then I think that, as always, of course, publication in high impact factor journals is a very good way to get a message out.